this type of drug sets the paradigm for these bispecifics, these MTACs, and it shows activity. And now we've seen this in other tumor types like myeloma. Now we're having clinical trials looking at other targets, not just GP100, because I agree with you, GP100, you think about it, you say that's melanoma, and we've presented some of the phase 1, phase 2 data of this drug in cutaneous melanoma showing above a 30% clinical benefit. But if you target other targets, and these are clinical trials looking at MAGE and PRAME and others that are found in endometrial cancer, ovarian cancer, lung cancer, you're now seeing a paradigm that you can utilize for multiple solid tumors. And we've also presented at SITC last year that these drugs, specifically tebentafusp itself, is very tolerable in combinations with checkpoint inhibitors, and you can have durable response. So we've treated patients with a combination of tebentafusp and an anti-PD-L1, and tebentafusp with an anti-CTLA-4, and tebentafusp with an anti-PD-L1 and an anti-CTLA-4, and shown that you can get responses. And in these early studies, there are patients who discontinued treatment at 2 years who we're still seeing with clinical benefit. That fits the paradigm with immunotherapy, right? Improvements in survival without real improvements in response. Durable response, even at discontinuation of therapy, and long-term clinical benefit. So I see that as the future. I'm interested in what you think the future directions are with tebentafusp and others.
I think the combination aspect of this is something that's so cool because of its specificity, whether it's tebentafusp against GP100 or something against one of the MAGEs or something against PRAME. I do think it's uniquely, kind of makes a ton of sense to combine with checkpoint inhibitors. I mean, we think that everything makes sense to combine with checkpoint inhibitors, right? Like there's thousands of studies looking at drug X plus a checkpoint inhibitor. But from an augmentation of toxicity, I don't think we're going to see that. We haven't seen that. You've shown that data. Others have shown that data. I don't think this is going to cause more pneumonitis or myocarditis or whatever, unless the antigen that you're targeting is expressed in those, those types of tissues. And I think that, the world of immunotherapy, that first, the first wave of immunotherapies with cytokines, the second wave of immunotherapies with checkpoint inhibitors, the third wave of immunotherapies is T-cell therapy. And this is a T-cell therapy. And it's just a different type of T-cell therapy. And as we're getting smart about what targets to go after, the T-cell engager aspect of this is really exciting. And I think over time we'll expand across HLA subtypes. Obviously, it's not, a great look to have a drug that only, that works preferentially in people who are white. And so from a diversity and inclusion standpoint, we need to actually develop products that can actually help patients of all HLA types. I think that's eminently doable and happening. And so I think that's another part of this type of approach. HLA A0201 was the most studied HLA subtype, at the NCI, and then sort of kind of expanded out from that. But we're getting smarter about this. We can target, many different HLAs. And so I think that's another part of the future, is expanding across HLA subtypes and doing this. Combination therapy is part of it, and better targets. So I think that the future is bright for this type of approach, and I'd be interested to hear additional thoughts on that.
Yeah, I think when you look at where melanoma is going, okay, and I'm prone to saying that melanoma sets the immunotherapeutic standard for other solid tumors to follow. The next step is T-cell therapies. And with the toxicities and the limitations based on performance status for patients to get adoptive T-cell therapy and CAR T therapy, this is a T-cell therapy that is off the shelf, that is outpatient, majority of it, and is tolerable. It also sets that, what do you want? For years, we've said the reason that checkpoint inhibition doesn't work better is because those T cells haven't made it to the tumor. And guess what this does? This literally drags the T cell to the tumor. And so it makes perfect scientific sense. It makes great sense in the form of non-overlapping toxicity and ease of application. So my thoughts are, and what we're seeing in our clinical program are, that the next step is the combination of these with other checkpoint inhibitors, other immunotherapeutics, and possibly even chemotherapy. And we'll see where it goes.
Yeah, I think, as you say, this is really a monumental addition to our ability to treat cancer generally and melanoma specifically. We are biased, but I think your statement is correct that melanoma has been the trendsetter for immunotherapy in cancer, dating back even to the cytokines of IL-2 and interferon, and then obviously moving through checkpoint inhibitors and to T cell therapies. So yeah, I agree. We have more work to do, but we'll continue to do it and hopefully continue to set the trends for effective immunotherapy in solid tumors. I think our time has come to a close. I'd like to thank you, Dr. Hamid, for joining me to talk about uveal melanoma and tebentafusp. I wish I was at the Angeles Clinic with you doing this, but fortunately this time of year, the weather's not so bad in Boston. So it's not like, totally jealous of sunny weather and warm days and in cool evenings. But I will be in about 4 months. So, and I look forward to catching up sometime soon. So any final word?
It's always a pleasure to talk to you about, the successes that have helped our patients. And I look forward to getting back together at some time in the near future to talk about the next steps and what we found out over the last, the future years with this therapy.
Absolutely. I'd also like to thank everybody who's tuned in. I hope you found this to be semi-entertaining, everything semi-entertaining to extraordinarily entertaining when Dr. Hamid's involved. And then also hopefully informative and helps to understand why we're doing this, what this drug can do for our patients with uveal melanoma, how best to utilize it, some of the potential cautions or at least things to know about. And then, a brief look to the future in terms of how this agent, perhaps alone or in combination with other agents, as well as other similar agents, maybe moving forward. And with that, I thank you for your attention.
Thank you.